recording right now. All right, thanks everyone for joining us. This is the first time we're coming back for season 2 of Residency Fellowship Seminar Series. I'm Vien, if you guys don't know, I'm a PT currently at Samaritan Athletic Medicine in Oregon State. Today we're gonna go over glenoid bone loss injuries as well as shoulder instability. Dr. Brian Waterman is gonna go over the first part, talking about surgical indications, and then I'm gonna go over a case study about rehabs. Some housekeeping though, if you can, wait till the end for any questions you might have, and you can certainly ask them aloud at the end. If you have questions that you might forget, you can definitely put in the chat and I can moderate it that way. With that being said, you're all good, Dr. Waterman.
Great. Yeah, no, awesome to link up with you. You know, for those of you that don't know, Vien was kind of like, he was the all-star that left. He's the one that got away. So we wish we could have kept him on the East Coast, but great to see you thriving, and obviously great opportunity for me to connect with you all and hopefully learn a lot from how to better manage these folks post-operatively. I always glean a lot from our rehab discussions, and especially as we get further and further down the rabbit hole, we know how much we don't know. As Vien mentioned, I'm out here at Wake Forest. We're in Winston-Salem, North Carolina, and so I work as part of a big team with Wake Forest University, but also Winston-Salem Dash, which is a White Sox affiliate. I do some stuff with you in ski and snowboard, and really just am very passionate about shoulder instability. I was a military surgeon for 10 years, and really that contributed to a lot of really trial by fire on shoulder instability. And so we learned a lot and tried to package some of these lessons within this PowerPoint. Just real quick, Vien, how much time-wise do we have again? How much time would you like me to focus on this? And I don't want to road into any of the further
discussion. I ran through my part. It's going to only take me about 15 minutes. So usually these things run for about an hour. So you could probably have 30 or 45 minutes if you want.
Okay, great. I think it may be about 20 to 25. And so that'll offer a lot of opportunity, but we can definitely deepen our pockets in some of the other areas. So feel free to flag me on anything or put any questions within the chat function just as a placeholder. But, you know, thanks again. Obviously, we realize that virtual learning is the new learning, and I'm really looking forward to talking about this tonight. All right. Can everybody see my slides okay? All right. So thanks. My disclosures, just by way of formality, can be found on the AAOS website, really none of which are reflecting any of the content that I'll present here. Again, I always like to pay homage to my military roots, and a lot of that is born out of Dr. John Fagan, who the fellowship is named after in West Point, and really has been a leader in the field. And a lot of his disciples are really the people that have informed my treatment approach on shoulder instability. Brett Owens, who's in the top center, was my staff as an intern. And so he has really led me to all the rest of these individuals. And I've continued to learn from them. And we've forged ahead a lot on these topics. And really, it's been grounded in everything from how to manage the first-time shoulder dislocator to the in-season athlete, to these more advancing scenarios in bone loss. And that's what we'll kind of talk about today. I always like to start with a case, and you can see this is a case that probably Vien is somewhat familiar with. It's a 20-year-old wide receiver. You can see him streaking to the end zone in a grudge match here with Virginia Tech, and lands awkwardly, sustained what's suspected to be a shoulder dislocation, and is evaluated in the training room or the locker room in order to assess him. He does have full range of motion. He has good cuff strength, but does have apprehension and some relocation testing in the absence of any posterior provocative symptoms. And so inevitably with these high demand athletes, we get an MRI fairly quickly in order to survey the damage. And these are the things that we can commonly see. This is an axial image of a shoulder MRI. You can see on the left shows the significant Hill-Sachs lesion, as well as stripping of the labrum and peeling back almost in what's called a glad lesion. And you can also see some degree of bony edema and swelling within the shoulder. So that MRI really offers us a good sense of what's going on. And this is really the gold standard for what's going on, trying to figure out what it looks like arthroscopically, because it's our charge to try to hatch a plan that really is going to not just get this player through the season, but what's going to provide him the greatest degree of stability for the long term. What we know is that these contact athletes and really athletes of a young nature in general have a high rate of recurrence. And the burden of disease is quite significant. They can have slap tears, posterior labral tears, 80 to 90% recurrence in these high-risk subsets. And so early surgery can definitely reduce that recurrence fairly significantly, improve their quality of life, and offer cost effectiveness of care. But as you know, that's a little bit of a tough sell. We often start talking about bracing options and return to play criteria. And very often we see these folks undergo recurrent instability. And so really we try to figure out who are those individuals that are best served by potentially an expedited return to play or patients that we should intervene earlier. Well, JT Tokish has looked at this fairly significantly and tried to define this non-operative instability severity index score. And what he found is using these criteria shown in the bottom right, that this may be able to form a threshold by which we can safely say that 97% of these folks with a score less than 7 can return to sport, whereas those that are more high risk, which tends to be contact athletes and those younger individuals, have a higher rate of not returning to sport, up to 12-fold higher. And if you have bipolar bone loss, meaning of the humerus and glenoid, then that's certainly one that's at risk. Well, say we do allow those folks to return to play. Well, what we know is that they can generally return in a fairly expedited timeline, about 5 days, full range of motion, full strength, get them in a brace. But what John Dickens has shown us is that while there's probably 2/3 of them that complete the season, only a quarter of these actually do so without recurrence. And so that's really not a good rate for success. Recurrent dislocations also do matter. And for every recurrent shoulder instability event, you can really continue to knock off more and more of that glenoid precious bone stock. And so even with a recurrent shoulder dislocation after a first time, it adds another potentially average of 7%. So that's important to realize. So in terms of management of these subcritical bone loss, how do we address it? Well, our study and several of the other studies have reflected that increasingly we're doing a soft tissue arthroscopic Bankart, which is probably the workhorse procedure for management of shoulder instability. But there's also an increasing utilization of these bone block procedures, or Latarjet being one. And so that trend will continue to bear out. This private payer database outside of the military shows a very similar pattern, right? In this younger at-risk patient population, increasing utilization of the Latarjet and scope Bankart. But really our question is well, who gets what and when does it happen? And there's probably some gray areas here. We always need to regress when we talk about these things with our athletes to really our fundamental tenets really is to minimize that risk of recurrence and to facilitate improved return to sport. So those are our charges. Well, first, it starts with a really good clinical evaluation. This really can inform a lot of what we decide to do. If folks have hyperlaxity, and hyperlaxity is distinguished from instability in the provocation of symptoms. If somebody has apprehension with a certain movement, then that is by its very nature instability. But there are a lot of folks that are on the spectrum of laxity. And so we really assess these Baden criteria, which are shown in the top right. We assess that inferior gonohumeral laxity, assess for the competency of that IGHL complex with a sulcus sign and a Gauge test. And that really can inform you a lot. So you check that on the opposite side, and that can really assist. Also, what we know from the military data is there's a high rate of concomitant injuries in the posterior labrum, not just anterior. Very often it kind of strips and goes all the way around in kind of a J-shaped fashion. So using this push-pull test that's shown in the top left, the Kim test shown in the bottom right in the cartoon schematic there, they can be very helpful and very sensitive for assessing these individuals. And if you have a hard time doing it because there's a bulky athlete, you have them lie down supine, have them bring their shoulder over to the side, and it puts you in more of an advantageous position for assessing that. Scapular mechanics is increasingly something you focus on, not just within your throwing athletes, but folks that have instability in general, because this is probably a modifiable risk factor for having further shoulder instability. Scapular dyskinesis is really an alteration in that 6 degrees of freedom within the scapula. And so correcting that with PT can be very, very helpful, as you know. This study shows that a dedicated scapular program can be 80% effective for those folks with multidirectional instability. And so we increasingly try to focus on tactile and visual cueing and really relying on our PT colleagues to be the boots on the ground to deliver this program. So when we define injury, though, it's important to realize there's a degree of structural damage, but then there's also some plastic deformation or stretch of that tissue. I tell patients it's like that pair of jeans that you've worn for too many times and they're just loose, right? They're baggy in all the wrong places. So we assess that with measurements of translation and rotation, and also try to inform how we're going to retension that. So you can see that IGHL was damaged with a Bankart tear or shoulder instability, but then also these other areas that need to be addressed. And that yellow region is one that I increasingly utilize to ensure success. We focus a lot about defining our terms, and knowing the pathoanatomy of the shoulder and shoulder dislocations is helpful. We often call this the alphabet soup of shoulder dislocations. And why these matter is because they often are associated with increased risks with increasing degree of energy, as well as stripping and damage to the soft tissues. What we know is that glenohumeral pathoanatomy is really key for understanding the management options. And so we need to not only just define what the soft tissue injury is, but also the osteochondral integrity. And you can see how this indention within the humeral head can be much more profound with increasing degrees of bone loss on the socket with engagement there. Plain films are probably good for establishing the presence of pathology, but really to quantify things, I think you probably need to dig a little deeper with some of these imaging studies. There's a variety of different special x-rays we can take in order to try to inform what that anterior or front part of the glenoid looks like, but oftentimes we're using CT scan, using a variety of different techniques to assess that. What we know is that 2D CT scan with adjustments to make sure that you're directly on face can have a very helpful role in determining these degrees of bone loss. But increasingly, we use these 3D subtraction sequences where you remove the humeral head in order to assess that bone loss. And really, this is the gold standard. When you look at studies that have evaluated this sequentially over time, 3D CT is definitely the market leader. And so that's what often we'll use in a scenario where I'm on the fence on whether to do soft tissue repair or a bone block procedure. I use this perfect circle technique where you format that inferior 2/3 of circle on it. You measure the diameter, and then you try to calculate the degree of bone loss or attritional bone loss or partial erosion of that wafer in the front. And then we use some various different other imaging techniques. Very often when we see these athletes, they come in with an MRI. That's very helpful for assessing some of the degrees of damage. I use it most likely to see what the ligament looks like, not on the socket side, but on the humeral side or the humeral avulsions, which sometimes are poorly seen and can comprise up to 3% of shoulder instability events. When you look at measurements of bone loss, Matt Preventure has really shown that you can probably use some degree of MRI and create these 3D MRI sequences that may be able to approximate bone loss as well. But I'd caution you about exporting this to your center because it can be very technically demanding. It really requires radiology buy-in, but it does have the added benefit of decreasing your radiation dose. Again, this is another study that looks at comparisons of bone loss by CT and MRI and then try to format that into our decision-making algorithm. 1 in 3 patients had differences in treatment based on their imaging modality. So know that there's a degree of precision that may lack in some of these studies And so go with the gold standard if evaluating things. One of the things you can often utilize in training room just based on x-rays and patient risk factors is this ISIS score. The Instability Severity Index score has been exported from Europe to our training rooms and our athletes. And increasingly, this has been used as a predictive tool to try to assess what athletes are going to fail with a traditional soft tissue Bankart repair. And what you can see is these studies from Europe show a decreasing threshold, lower and lower, with each subsequent publication, and to the point where you see the risk factors on the right. If you're less than 20 and you come in playing a contact sport, well, you've already medically bought yourself a Latarjet or bone block procedure. And so is that effective? Well, what we found, and when we looked at it in the military, is that this total ISIS score was not predictive of failure. In fact, we did a pretty good job with Bankart tears, and that these both composite sum of the ISIS criteria as well as the individual subscales did not predict the requirement for revision or failure. One of the things that you'll also hear about is this Glenoid Track concept. And so let's distill this down. What the Glenoid Track concept is this concept of engagement of your glenohumeral joint. So if your tire goes off the road, it's off track, it falls into the rut. And so that's what's classically called that engaging Hill-Sachs lesion shown in the bottom right. So very often we use some of these imaging studies in order to assess the on-track, off-track lesion. And I'll save you the arithmetic, but what this is just simple calculations that try to assess whether that Hill-Sachs interval, meaning over here on the humeral side, is this larger than the defect that's going to be present there and allow it to fall into this rut. And so that's just some of the algorithm. Feel free to review that concept at your leisure, sometimes a little bit more technical than we'd like. But what's the clinical repercussions of this? Well, on-track lesions, which again means non-engaging Hill-Sachs lesion, the rut that's not encountered on the front part of the socket, had failure rates of 8% versus 75%. 3/4 of patients with off-track lesions failed after their shoulder stabilization procedure. So that's pretty powerful. But the elephant in the room is that socket side is what we've prioritized, but the Hill-Sachs lesion, that lesion on the humeral head, really is one that we've yet to devise a system that accounts for the depth, the location, and really the severity. So know that we're deficient in how we quantify this, and this is our best technique for assessing available bone loss. So what is critical bone loss? And this is what Vien really gets charged up about is that gray area in between. He wanted me to talk specifically about those individuals with glenoid bone loss less than 20%. Well, increasingly, when you see this critical threshold, 13.5% tends to be the one that is more of the modern threshold for severity in glenoid bone loss. So when you look at this study from the military, again, what you find is that folks with greater than 13.5% bone loss had lower patient-reported outcome measure scores and subjective satisfaction, even when you excluded those that had recurrent instability. So with or without recurrent instability, these individuals were worse off with that degree of bone loss. And so, I'm not routinely calculating that glenoid track concept. I use this concept, what I call the flat glenoid contour. If you look at this parasagittal view or this 3D reconstruction, or even your X-ray, if it shows you that you have a flat anterior glenoid, this probably roughly approximates to 13%. And that individual, if it's a contact athlete, I may increasingly consider not just can I do a soft tissue, but I need to do soft tissue and something. And very often that and something is a bone block procedure. So know that this is a good, rough, poor man's CT scan and assessment. Estimation of bone loss really informs our algorithm. So you see your red, yellow, and green lights. you're considering that arthroscopic repair for those lower bone loss situations, less than 7 to 10%. That mid-range, kind of exercising caution. You want to make sure you're adding something else. Remplissage is tacking a little bit of the rotator cuff into that Hill-Sachs defect in order to try to allow it to not engage, or maybe it tethers it towards the back of the shoulder so it doesn't come forward and engage on that front part of the socket. And really, for those greater than 15 to 70%, I'm considering an open bony augmentation procedure if it's a young, at-risk athlete. You can see this is how we assess the patients in the operating room. You can see I've placed it anteriorly and then performing a reduction. You know that is an engaging Hill-Sachs there. You can also see the degree of posterior instability too. So this is really a bidirectional problem. I think about it like a concussion, right? One side is encountered, the other side also has a contra-coup injury, and very often we see this circle concept borne out in the shoulder as well. You can see this is what the arthroscopic images look like. You can see the humeral head on the left, the capsule and rotator cuff. This patient's lying in the lateral cubitus position. You can see the socket at the bottom part, the labrum, and you see all that red stripping of the capsule, and the labrum is kind of absent. It's peeled back there. So how we manage this, we first get a lay of the land and quantify our degree of bone loss. And really in these cases, I still think that a capsulolabral repair is an option. Bankart repair with a well-done technique really can be a very successful procedure, but you need to exercise caution and observe all these technical pearls. So you can see some of these images here just reflect how we approach things. You can see we're placing 3 anchors at a minimum below the equator and fixing that posterior inferior labrum in order to augment things. And these are the pearls that I typically review with some of the sports surgeons that are more interested in kind of the individual techniques. But I mention this because a lot of this stuff does play into how you evaluate these athletes in the operating room and in the clinical training room. You can see knot migration is a real thing. As we try to tether these soft tissues back together, you can see those knots can sequentially roll onto the surface. And so you may encounter squeaking or irritation, catching or locking. And that's something that, if persistent over time, is definitely concerning because that can abrade on the humeral head. So increasingly, we're looking at knotless ways that we can address things, where we're leaving less signs of our intervention and trying to, again, adequately retension the labrum and soft tissues to the socket and allow that shoulder to be much more stable. In terms of that Hill-Sachs, right, that humeral head lesion, what we do is we often prepare that using a curette to try to create a nice bleeding surface. And then we tack a little bit of infraspinatus tendon in there and capsule in order to try to prevent, again, that translation. You can see that after it's been fully prepared in the right image, nice cancellous healing bone, and very often that tendon will remodel into. We tack a little bit of that infraspinatus in. So what we know is when we do that, it probably leads to a little bit of loss of external rotation, mostly in full adduction, but sometimes up in the throwing or at-risk position as well. And you can see it in this video here, tacked in quite nicely in this right shoulder. This is just reviewing kind of the bird's eye view of those techniques and kind of a more sequential approach. Anchors placed in the humeral head, then subsequently into the glenoid, then go back and tie that Hill-Sachs lesion. What we know is that the time to do that really is at the time of initial treatment, because when you go and do it at the time of revision, it doesn't have a tendency to do as well. In fact, the failure can be quite significant. So when is an open procedure indicated? It's, for me, when a failed arthroscopic stabilization is present, when there's critical or combined subcritical bone loss, when there's folks that have subcritical bone loss with significant at-risk activity, like your Oregon State football player, or a contact athlete. And that's one where you may consider an open Bankart or an open capsular shift as well. And you can see some of the imaging shown here. For me, the workhorse is definitely still the Latarjet or coracoid transfer. You can see this image shown in the video here, a patient we have upcoming in the coming weeks. You can see that attritional bone loss, he's fragmented, he has instability in the lower degrees of abduction, has problems getting dressed in the morning. So that's a real problem for folks, and it can lead to worsening arthritis. The goals of Latarjet are really to use what we call the triple effect. It's to increase the size of the half pipe or the golf tee, use that conjoint tendon as a sling to hammock and provide that shoulder stability throughout the anterior instability, and then to repair that capsule. This is what the procedure looks like and how we prepare them. We often use a subscapularis split. That way we know that there's morbidity with taking down the subscapularis. It can create fatty atrophy. It can lead to attritional loss of tendon. And so we try to preserve that as much as possible, and going through a longitudinal split seems to preserve that. Retractors are helpful for getting into this very deep, dark hole. You can see the exposure shown here, where it's almost like a bikini strap incision. You can see in the bottom right here, you can see the 2 screws and the little small washer there holding that plate into the socket. You can see the graft needs to be directly adjacent to the socket. If it's too proud, it can be an issue. And so you want to make sure that you're doing what you can to restore those normal loading mechanics. And again, just another image showing the Latarjet procedure. There's a variety of different techniques. Again, I won't bore you with the specifics, but just know that there's a lot of variety here. And some of that may impact the way you treat these folks in the rehab scheme. But what you know is that postoperative CT scans at 4 months, if it shows adequate union, these guys are ready to play ball. They can really start with a return to sport progression and start to really test this repair, because bone-to-bone healing is much more stout and sound than the soft tissue Bankart, which usually requires up to about 6 months for return to contact activity. An arthroscopic Latarjet, know that it's a very technically demanding and complex procedure, but it is on the horizon, and it may be something, at least in some fashion, that we see coming into the United States more and more. What's the outcomes like with bone block reconstructions? Well, we know, whether that's a Latarjet or other techniques, that it can be very successful in recreational and competitive athletes. You can see the risk of recurrence is very low, less than 0 to 3%. You actually do quite well in the studies. I would say it's not for the average Joe, though. If you have an athlete that requires this treatment, you definitely want to get them to somebody that can address this problem and try to mitigate risk of short-term complications, because these are real and they're very profound for your athletes. This was a study, and I'm humbled to say that we documented our results early on, and it showed some degree of complications within 25%. So experience matters, and as we've gone along further, we've seen improvement within our complication rates, thankfully. But like any procedure, there are definitely these disasters. This is the combine data from Latarjet folks that are coming through, and you can see the rates of hardware complications: fractured bone blocks, non-union of a coracoid process, bent screws, broken screws, and then progression to arthritis. These are real. So know that this is not the end-all be-all for our patients with instability, even in the high-risk patient. You really want to exercise good technique and choose our patients wisely. Alternatives, you can use fresh allograft from an ankle, distal tibial allograft. It's very helpful for those individuals potentially with revision or more extensive areas of bone loss. You can use this iliac crest from the pelvis. You can also increasingly use distal clavicle autograft, which is still in the transformative phase of kind of being rolled in and the indications are being defined. But JT has really done a good job in helping to lay that out for us. How do you manage the failed Latarjet procedure? Obviously, that's a bigger topic for a different day, but this distal tibial allograft is probably our go-to for that type of scenario with excellent rates of union and success. So with that, I'll transition to case 2, which just demonstrates some of these elements, and then we'll finish up with our last case. This is an 18-year-old male, high school athlete, has a right shoulder dislocation. He's had prior history of instability events, but this one's different. He really had a lock dislocation, required reduction in the OR, and he wanted to return to play collegiately where he had already signed. He had evidence of apprehension. He had guarding with posterior load shift and had some mild provocative bicep symptoms, but otherwise nothing much going on with his cuff or scapula. These are his images, and you can see some nuanced findings in the front part of the glenoid. You can see that little wafer here, and the suggestion that potentially there's a little small Hill-Sachs here. Our advanced imaging shows that there's a labral tear, potentially extending posteriorly, some degrees of bone loss. You can see this loss of normal contour here. And so if you follow that through on these sagittal sequences, again, you see that loss of normal contour here. These are just the coronal sequences. And then we ultimately obtained a CT scan for this guy with high rates of instability. Bone loss was suspected based on the contour that we saw there. And you can see this attritional bone loss here with this inverted pear appearance. So the 3D reconstructions, you can see that flat anterior glenoid. This very thin non-structural wafer here. So that's an individual that I indicated for Latarjet. You can see at first blush on this arthroscopic image, you see the rates of, or I'm sorry, the association of a combined split type 4 slap tear, which extends into the biceps, has this bucket handle component to it. And this young individual, we elected to try to repair that. And so you can see we prepare his Hill-Sachs, we perform a slap repair in association with it. And then in his case, I'm not sure. We also extended that repair down towards the back to try to treat that posterior labral tear. So you can say incorporating this bucket handle tear within the superior labrum and tacking back down, all before even doing our Latarjet. And you can see our images here, which I'll play for you, showing our anchor fixation and then final reapproximation of that superior labrum. An attempt to get healing for this otherwise young individual that's at a high risk for recurrent shoulder instability as well as arthritis, given his degree of wear. We do the remplissage, which is that anchor-based repair into that defect. I won't bore you with those surgical videos. You can see reapproximating the rotator cuff tendon into that defect. You can see how nicely that keys back in order to fill that defect and prevents engagement of that pothole. Final images showing that glenoid reapproximated from the anterior superior view. And then you can see then we proceed forward with the Latarjet fixing with 2 screws in this washer, which helps to compress that bone block more effectively into position. You know, so in this individual, a Bankart repair with remplissage was undertaken in a case we showed earlier. I think that that's a good technique for those with subcritical unipolar bone loss. It has a high rate of return to contact athletics, upwards of 75%. There's modest rates of recurrence, so never diminishes to 0. It's about 8%. There's low rates of complications. In terms of bone block procedures for our contact and high-risk athletes, there's also a high rate of return to competitive sport with much lower rates of recurrence. I usually tell people about 0 to 3%. However, there's radiographic signs of osteoarthritis at mid to long-term follow-up, and so that's something we need to counsel our patients on. Again, this is the algorithm that I think is very valuable to export to your patients, and so certainly take a screenshot of this, share this, and engage your clinical teams in order to decide the best first approach to treatment of these athletes, because very often that's your best shot at getting it right. So with that, I'll take any questions or segue on to Vien for the more interesting part of the talk.
Thanks, Dr. Waterman. It's just a reminder, it brings back to Fridays where we think we know the shoulder somewhat as rehab specialists, and then you just drop so much literature on just like the glenohumeral joint alone. So it's really cool to hear that. But yeah, let's do questions at the end just so it can be a little more concise. But could you make me host and I'll start my share?
Yeah, absolutely.
Nice shirt, Ada.
Make host. Perfect.
All right. Let me start my slides first.
Hey, Ada.
Hey, thank you.
Right. All right, so thanks, Dr. Waterman. I'm going to go over a case review now, kind of go over an example of what happened when a patient failed their, or I'm not going to say failed, but their Bankart repair didn't do well. So this was a patient that was a 19-year-old D2 lacrosse commit. He was a face-off specialist. So they don't get a lot of field time because they quickly come off. But as you can see, just from the different moves, they do get a lot of action on their arms, sometimes even weight bearing, and even some kind of plyometric properties in their movement where they're fully weight bearing that arm. And keep in mind, they're going to be across from someone that wants to take them out as well. So he had chronic dislocations his whole life and finally got a Bankart repair. But 4 months in, even when he wasn't back to sport, he started getting chronic dislocations again. When he saw a surgeon, this is what it looks like. Honestly, Dr. Waterman, I don't even know what I'm looking at. It could be his knee for all I know. But I just went into his charts and found that. And he had a Latarjet revision, and that's when he saw me at 4 weeks after his operation. In case anyone wanted to know, his Bain score was 5 out of 9. So I wanted to look at a bunch of protocols for the sake of this case study. There was a good study looking at Latarjet protocols as well as Bankart repairs. So this study sought to see what the literature said comparing all the Latarjet studies out there. Of all the Accreditation Council for Graduate Medical Education institutions, only 18% had protocols. So that was only 14 of them. And then online, they found 17 other ones. So out of all their World Wide Web and literature, there's only 31 total protocols. What they found here was that full range of motion passively was achieved at around 8 weeks, and then full active range of motion was around 10 weeks, but you could see that was very variable based on the protocols. And then looking at resistance training is a gradual progression, as a lot of us see, starting out with isolated first and then going to free weights. Interesting, bicep curls were at 10 weeks. Weight bearing was at 9 weeks, and plyometrics at 15 weeks. And again, there was quite some variance, even if you look at the free weights number of 10.5 weeks plus or minus 4.5. In one study, it said that return to sport for non-overhead athletes was 16 weeks, and then for overhead athletes, it was also 16 weeks. So a little confusing there. There's not really consensus agreement in all these protocols. I think the funniest thing was a protocol said that you start bench press at 16 weeks, which I get because you don't want to stress the anterior structures, but also you start upper body ergometer at 16 weeks, which doesn't make sense. But you can start the stationary bike before that. So really, I was just confused about everything. It just shows that there's no clear-cut protocol in that, and probably ask the surgeon specifically, because the only person that sees inside the patient's shoulder is most likely the surgeon. For the study part where they looked at it compared to the Bankart repair, you could see that in general, Bankart repair was took a little longer as far as the rehab went on certain stages, especially return to sports. This was based on the Bankart repair using sutures versus screws for the Latarjet. Despite being significantly delayed milestones with the Bankart repair, return to sports was still roughly around the same time. So about 6 months versus 5 months. And although you can go a little faster with the Latarjet, obviously there's more bone loss and it's just not quite the same. It's more of a severe surgery and injury. The return to sports rates weren't the greatest compared to return to sports either, but overall, both were really good. So what I do with this athlete, so the recommendations for this athlete were to regain active range of motion early on. Again, I got him at 4 weeks. It was to perform passive range of motion, start weaning off the sling, and then slowly progress external range of motion. So I don't know about you guys, but whenever I get an athlete who has a revision stabilization surgery, I am usually never needing to stretch them. And first day I saw him, he actually had full range of motion already. So I chose not to stretch him. I feel like he's someone that's going to get it back. I know the protocol said bicep curls at 10 weeks, but I did BFR right away. Just because he had full range of motion, there wasn't much other stuff I could work within restrictions. So had him come twice a week. I didn't want to do, I don't know, protocol is kind of referred to 3 times a week, but I just felt that might have been poor utilization from insurances. And then we started isometric ER/IRs within permitted ranges. At 3 weeks, this phase, usually you want to strengthen, making sure you don't overstress the anterior capsule and you're just trying to gain the strength back. He had good stability by then, just using rhythmic stabilizations and all. So I allowed him to do front squats on his own, just because I felt like that was safe for the shoulder. He wasn't in that maximally external rotated position. We started doing pull-ups, just holding, just gain the endurance. And then with the bench press, he had a massive chest. So I really only had to use one pad to kind of block the bar from having his elbows go past 90. Still continued strengthening everything else, and then introduced deadlifts around, I'd say 13 to 14 weeks, just from the tension of gripping it, as well as starting overhead strengthening a little bit later, or technically earlier in the overall rehab protocol, but later in this phase. And then at 4 weeks, when most of them, the protocol say to return to sport, this is only when I allowed him to do a back squat, holding the bar regularly, just because he's in that external rotated position again. Allowed him to catch cleans, work on velocity. So we didn't get the power from the heavy weights, but more from the speed component. And then because he was a face-off specialist, he could just practice his moves on his own. We also used the Kaiser functional machine. We just put the arms down, attached the pole to one end. And then we, something I did was I just varied the resistance, and he didn't know it, so it was blind. So he had to kind of like pull randomly on that to give him some kind of unpredictability. So this was a little more advanced and faster than most protocols, but I actually didn't allow him to go back to sport as early as these protocols did, just because he was getting a lot of chronic instability even after his first surgery. So the biggest thing is at return at 4 months, this is when I tested him if he was strong enough to go back to plyos. This is probably going to be controversial, but I was actually happy with this motion. It was 155 versus 180. For me, I didn't stretch it. I still didn't continue to stretch it. I felt like he was very functional now. This was someone that was constantly dislocating. So for me, I actually want his shoulder a little stiff. And I would expect through the years, it's going to get a little more lax. I don't feel too bad because in 2018, Yang published a study looking at the outcomes, and the usual internal rotation measurement was 50 degrees at that point. So I actually got a little more than that. These were his testing scores. So we look at isokinetics. His LSI for external rotation was 110. I was actually expecting 75 at that point, but he crushed it. Because they do split the subscapularis, we're expecting some weakness in internal rotation, but he also crushed it there. Looking at peak torque to body weight, I think the preference is around 18 to 25% for males, and he fell within those ranges too. Looking at the faster speeds, these should actually go down, but he actually went up on these, and there was no coefficient of variability. So he did the test correctly. For some reason, again, he was just crushing it. And then for passing at final return to sports, it should be around 66%, whereas it's recommended 75. I'd say he hit within that range of 72%, looking at the posterior cuff ratio to the subscapularis. He got 41 on the upper extremity close kinetic chain test. That is an insane amount. Usually 20 is passing. I consider for Division I football players, or we'll say high level lacrosse players, I consider 30 to 35 passing. So you could see him do it, but you could see him cheating a little bit, looking at him touch his wrist rather than his hands. One thing I don't mind is, if you can think about it, it's kind of like mini plyos on his arms over and over. And what we do know is that this test isn't predicative of anything. So I looked at more of, is he willing to do the movement? And he had no fear at all. He passed the first time, he still wanted to try to get like 50. So I knew he wasn't fearful, especially with a chronic dislocator. I figured that's probably risky behavior, if anything, but he was doing good. We did seated shot put at this point. I wouldn't expect him to be passing. Passing would be 110%, which he got 115%. And then quick dash, he had 0% on disability and sport as well. So what now, right? He passed all his test return to sport, yet he is only 4 months out. And most people would let him play, but I didn't. So he loved to play basketball. If he wanted to do that, he actually came in on testing day saying, hey, sorry, man, I'm a little sore. I just played 5 straight games of basketball. And I said, all right, let's not do that. So I had to calm that down. But the other thing, he was a total meathead in the best way. He probably think that was a compliment. So he was plenty happy just to lift in the gym. But the biggest thing with this pastime is I don't think lacrosse was his true love. It really was Dungeons and Dragons. He would come in on Saturday saying, hey, sorry, man, I'm on 3 hours of sleep, just because he and his friends would just stay up doing this. So the good thing is he's a competitive athlete, got after his rehab, really motivated, but he also had other things to lean on. Unfortunately, COVID and the finish of my fellowship made me leave, but I did keep in contact with him, gave him a call about a month ago, about a year and a half out. The way I look at my outcomes is it better than what the research usually says? So again, this was pulled from the Yang article in a Latarjet revision group of 91, with 24 of those athletes being contact sport athletes at a 3-year follow-up. You could see that at 1.5 years, mine were 0. So it's better for disability, better for the SANE score, and better for pain. They didn't have the measurements for just contact athletes, or they didn't present those, but at 4 months, we beat those measurements. So again, I thought I was being a little conservative on the stretching, but it looks like may have been aggressive, not even doing anything. And then recurrence, of course, there's a 0% of 1, but he did return to practice and lifting with his team, but they didn't really do any competitive sports yet, just because of COVID itself. So those are my references. Thank you all for joining. That was just my kind of case of how I took that. I took long, try to be slow as I could, but obviously he, just like Dr. Waterman presented, his measures and his clearance would have been probably good for anyone who needed to go back to sport that early. So if there's any discussion questions now, we can take them. Otherwise, I'll just kind of rattle off. Does anyone have anything to start?
I have a question on range of motion, I guess, after bank art versus a Latarjet. You know, it's interesting going through your range of motions that you listed off there. Vien, in your case, he had 90 degrees of external rotation, which is great. You know, that's normal, especially for a non-throwing athlete. Though maybe with being a lacrosse player and getting back there, that might be even getting you back into those further ranges of external rotation, range of motion. I guess my question is, if you start to run into a stiff end feel with 80 degrees, 85 degrees of external rotation, is that something that you think you'd worry about in a Latarjet? And would that answer be any different from like just a regular bank art soft tissue? I'm curious to hear from like even both yours and Doc's perspective here.
Yeah, I'd be interested in hearing Dr. Waterman's opinion on it. For me, I've actually seen that before on it was a failed bank art repair, Latarjet revision on a non-athlete. And with that one, it was so stiff. I was so worried. It was like 4 months in and we didn't even get to strengthening yet. And talked to the surgeon. They said, I mean, technically we fixed the problem. It's a stable one. For athletes, I'd be a little worried that I'd want that, but I wouldn't know what the surgeon would do. I don't know if they do like a manipulation under anesthesia, if they're okay with that stiffness. And then certainly when we get into throwers, that's just a whole different conversation too. But for me, I wouldn't be worried with, like you said, 80 degrees or so, or
yeah.
I wouldn't be worried personally, because again, I do think they're going to get that as they do more activities like throwing random things with their friends. They're going to get that motion back. But what do you think, Dr. Waterman? Is stiffness okay?
Yeah, I generally counsel people there's probably a 10 to 15 degree difference versus their uninvolved side with a primary bank art repair, so a soft tissue repair. It's a little bit more variable in a revision setting, and then Latarjet, just because there's so many different ways in which we address things. One of the things that I usually do is I'll put them up at about 30 degrees and 30 degrees of external rotation. So 30 ABD, 30 external rotation. And then that's where I'll perform a soft tissue repair. And after the end of that, if I can't get them up into a 90-90 position, then I'll just pop some of those sutures out and I'll just let it be. A lot of people don't even do soft tissue repair there, but I want to make sure, especially for those folks, that I am sending back to the field, and I want to do so confidently that I'm not setting them up to even jump that bone graft. So I usually will repair that if there's substantial enough tissue. I would say 80 to 90 degrees is pretty achievable. As you get older, or as it gets to be a more revision scenario, those people get stiffer. So you definitely want to engage their range of motion early and make sure that you've got good fixation. Truthfully, the onus is on us to make sure that that happens, because a lot of that has to do with our screw trajectory. If you imagine that's your socket, you want to make sure that your screws are pretty much in line with that socket in order to make sure that you've got good fixation. If it's kind of off and you really don't have the best bone that you're achieving fixation in, well, then that's going to toggle and that's going to loosen early. But I want you guys to stretch it. I don't want them to get exposed to a contact situation. And that's where these can often fail.
Yeah. Thanks, guys.
Thanks, Dr. Waterman. So you actually answered the first question, giving those two kind of survey questionnaire types. So that makes it really useful, because we had a player in a certain sport dislocate, and it was so hard for us to go through the decision-making tree of, do we do surgery if it's literally the start of the season, or just try to rehab them? We didn't know what the criteria for either bone loss was. Obviously, it was to rule any kind of neurological deficits, but I guess we could use the ISIS for figuring that out.
Yeah, it's an interesting discussion. I mean, as you and Ada can attest, it's something that you can throw as much data at the person as they like, but a lot of times it's an emotional decision. If that's a high school athlete who's finishing up their senior year, I mean, they're getting back to play. If it's somebody that's in their junior year and they're looking at prospective colleges, obviously they're eager to return. If it's somebody that's early on in their eligibility, they can redshirt, then maybe that's something they take a pass. But more often than not, the stance I take is, look, you have a high risk of recurrence. If you do have a recurrence, it could change the procedure that you give, but I'll support you either way, and here's the data. And I let them make that decision, because I could tell them they need surgery, and they're either going to go to talk to somebody else and get a different opinion, or leak out to the system. So I usually try to do that shared decision making, and more often than not, they return to play. If they re-dislocate, then you need to re-image them, though, just to make sure you have a sense for what their instability is like and the level of bone loss, because that's real.
Thank you. And the next one, again, looking at range of motion, do we want to get early range of motion, full early range of motion with these revision patients, or what do we do with throwers? I feel like I would have been a little more aggressive with it with throwers, just because they're going to need that again, or not. I don't know. That's why I'm asking. Yeah,
I mean, and I'd lean on you all for your experience, really, to let me know what I can expect, because you see them in the early going. I think that I'm a big fan. I'm an advocate of early postoperative rehab, and that's through a stable arc of motion with active assist. I think aggressive passive range of motion is always concerning for me in this type of scenario. So in that first 7 to 10 days, it's just working on the pliability of the dynamic stabilizers, as well as some of my tissue repair, and trying to get a sense for whether these people are early responders, right? Because we see this widening gap in patients. Some people that are just inherently risk for stiffness, and those that really respond well and progress back at a much quicker phase. So I think the revisions are definitely ones we're more concerned about recurrence, but if you're going to a bone block procedure, I think that's one you can have an added level of security with the consent of your clinical team. In terms of throwers, I mean, those are tough, right? I had a pitcher / quarterback that we operated on probably about 3 months ago. And as you can imagine, the family was fairly direct about what their desires were and their expected range of motion. So in that guy, I probably take a little bit less soft tissue and I don't tension as much. And I also work very closely with our physical therapist to make sure that we have some preset goals. But within 6 to 12 weeks, our goal is to try to get fairly normal forward flexion abduction, and know by about 12 to 14 weeks, my goal is to have fairly normal internal and external rotation. If we don't have that by that juncture, I'll either do an oral steroid pack or I'll do an intra-articular steroid injection to try to titrate them back to normal. I've only had to maybe do 1 or 2 stiffness cases for over-tensioning, and those are probably errors on my behalf. So it's pretty uncommon to have to do that to restore normal range of motion.
That's useful to know what other options there are too. With that, I mean, you kind of answered it too. Obviously, I'm not going to go up to the surgeon and be like, well, what were the angles of your screws, right? Like that's just overstepping. But I think it's important to have a conversation with them because just like you said, you can tell us if there was a little more soft tissue involvement with your surgery. So that might help us decide on how hard to go over it versus leaving it alone. But can anyone think of any questions they might have for a surgeon if the protocols were kind of wishy-washy? All right, we'll move to the next question then. So the athlete's performance coach programs ollies. So I know there's variations where you don't have to catch, but when do you all allow snatches and cleans? I don't have the answer for snatches, guys, but cleans I'd feel comfortable at 5 months after they're doing some plyos.
I think that would be.
Again.
No, I'll let Mike take it over.
Vien, I was just going to ask, I saw in your case, you had your athlete doing front squats. I don't remember the date. I want to say it was somewhere between 12 and 14 weeks. Was just curious how you made that decision. And if you're like kind of considered other options, kind of, I guess, to work up to that.
Yeah, I didn't. So I was not going to put him on the isokinetics because I feel like that would is way too intense for his arm. But at that point, we moved through manual resisted ERI exercises. I didn't do the one where I'm like overpowering him at all. I did rhythmic stabilizations. We were doing isometric push-up holds. We were doing deltoid raises. So we did a lot of upper body stuff already. And at that point, just teaching him good positioning, putting it right on his acromion and not actually like the shoulder joint, that helped him a lot too. And then if he needed, there was also straps that we could support and unweight it. But otherwise, I felt like at that point, his shoulder was strong enough to support the weight. Luckily, he was deconditioned too, so he wasn't hitting 2 plates at that point. It was just getting volume and work capacity back in. So we were doing the God forbidden 3 sets of 10, 4 sets of 12 kind of deal.
Gotcha. I mean, this is totally,
that's right.
No, so this is totally anecdotal. I mean, I've had conversations like with our baseball strength coaches about, do we have, pitchers front squat and do we have them catch the bar and things like that. And oftentimes, we just feel like it's not worth it. And sometimes I think the same might be true, especially for revision and stability. And so maybe, these guys either are goblet squatting or they're safety bar squatting or they're using, kettlebells or something like that instead of doing Olympic lifting just to minimize the, because I mean, I'm not a believer that you have to catch the bar. I mean, if we're thinking about just using Olympic liftings for generating power, you don't necessarily have to catch it. And so there's definitely other things you can do. And same conversation goes with front and back squat. I mean, it's not like you have to do it. There's certainly plenty of athletes who have modified routines even long after they go back to play, just to kind of maximize their shoulder health. So if this is something that they want to get back to, Just being aware that there's certainly other options that you can kind of use to buy yourself some time. Unless the athlete obviously is demonstrating proficiency and safety, that's a totally different story. And it sounds like your player was doing well, but just was curious your thought process there.
Yeah, and I agree. I would not personally have them do snatches. I think a lot of performance coaches majority are against snatches. I don't disagree with them. I think it's just technically very hard for people to get the motion both in thoracic spine and upper extremity. But for me, because he was coming into a school where I did not know any of the medicine staff, the sports medicine staff, or the performance team, I didn't know how the information would have been communicated. So they might, if the team's doing hang cleans, they might just do hang cleans. So my idea was, well, if he had to do this, could he withstand that? And I never got to see him get past 115 on hang cleans. So I don't know how he's gonna look out, but that was my thought process. If he was thrown into a situation where he just forgot to tell them, or they were unaware of some restrictions or surgeries, then how would he do with that?
Hey, Vien, when do you all let somebody go back to body weight hanging exercises? So obviously we have a big CrossFit population and folks that are engaged in, these chin-ups, pull-ups, kind of this sometimes more aggressive kipping motion. I worry about those just from my time in the military, because the few failures that I see has generally been in that for PT tests, but be curious to know when that would be incorporated.
Yeah, so that is recommended around that 4-week mark. But as you could see, I started that around the phase 3, 10 to 15. That one was a variation of more like I call it like a pull-up plank. So they're at a box, they're in this position, so they're not hanging in that exposed position. And they're just holding for 10 seconds to start, and they're building their way up to 20 seconds. And then around here is when they'd be comfortable doing full pull-ups. I expect them to get weakness just for the Latarjet and the involvement with the subscap, but I would usually put it later, although I'd add like some kind of loading progression there. Some other things we did before we did actual pull-ups was just lat pull downs, and with the Kaiser machine, he would pull it down and we'd increase the air until he felt like it was a challenge, and we decrease the air. So just giving him isometric and stabilization there. So to answer your question, I think normally later end, maybe like 14 to 15 weeks or so, but for him, yeah, I did a hold that early on in phase 3, and maybe anyone else can answer that too. And I'm also open to changing, Dr. Waterman, if you think that's a bad idea.
I have no idea, truthfully. The other thing that's interesting, go ahead.
I guess my answer would be the same, just like start to progressively have them do pull down variations. And once they get to their body weight, they can progress to the pull up there. And I think even just starting with like some of these monster bands that you can tie up to the platforms and they can step into those, start with that, even if they're at their body weight. That'd probably be my recommendation if somebody asked me.
The other thing that I was going to mention is that there's been some great new work that's come out of Pitt. Albert Lynn is the surgeon champion, but as you know, they have a great PT and investigative team there. They've been looking at a more codified return to sport criteria for contact and non-contact athletes. And what they've showed in their most recent kind of limited pool data is folks that cleared their return to sport criteria had upwards of a 90% success rate versus those that did not were much lower, somewhere in the 60s and 70s. So I think being on the lookout for that. We obviously have seen the value of that in the ACL, but we're so far behind on so many things in the upper extremity. So there's definitely room for innovation, and I'd love to see things to come out of this great group on how to guide that progression. Because it's not one size fits all, and 4 to 6 months is probably not built for everybody.
Yeah, so Rick is the PT over at Pitt. You got any insider information, Rick, on what the test for non-contact and contact athletes, any of that work?
The best part is that Dr. Waterman is definitely not talking about me. I think he's talking about Popchak, who does a lot of our shoulder research with Dr. Lin. I would agree. It's like all the stuff that's been presented tonight is what we use as well. The same types of measurements, the incremental progressions of range of motion and exercises, and then the same strength tests as well.
Thanks, Rick. Yeah, I'll look out for that. I know at TCC they were talking about having return to sports be very different for contact versus non-contact versus throwing. And I think in about 5 or 6 weeks, Merritt's going to go over that and talk about after testing they've cleared that, what they're going to, other considerations they're going to have to take into. So the answer would be, I don't know, unfortunately. And then any measures to monitor over the course of their athletic career? Are you looking at their range of motion, like with the knee? Or are we just constantly checking extension? Is there anything anyone monitors in these populations? I currently don't. Open to any suggestions though. All right. I think that's it then. But yeah, I'd like to thank everyone for joining us. Thank you, Dr. Waterman, so much for giving the foundation of today's lecture and going over shoulder instability and how to manage those difficult decision makings for people with critical loss. With that said, if there's no other questions, thanks everyone again. Next week, Ryan and Glenn Clark are going to go over athlete monitoring and how that plays into return to sports decision making and how you can use that as they're getting back into it. So thanks again for everyone for joining, and we'll be back next Wednesday.
Thanks for having me, Vien. I appreciate it.
Thank you.
Everybody
so much
stay safe and feel free to reach out if you have any questions.
Yeah, I'll send an email shortly after this.
Perfect. See you guys. Take care.